When adults with ADHD describe their emotional responses to perceived rejection, they report something that goes beyond ordinary sensitivity to criticism. A brief negative comment in a performance review can generate the same intensity of emotional pain as a major personal loss. An unanswered text message can trigger hours of shame and despair. This phenomenon, which psychiatrist William Dodson termed rejection-sensitive dysphoria, represents a poorly understood aspect of how some brains process social threat. Common interpretations often frame intense rejection sensitivity as a character issue. If you feel crushed by a delayed text message or devastated by constructive feedback, conventional wisdom suggests you need thicker skin or better self-esteem. Even mental health discussions frequently treat it as a subset of anxiety or depression that responds to standard cognitive approaches. But rejection-sensitive dysphoria operates differently from ordinary sensitivity to criticism. When Naomi Eisenberger's team at UCLA conducted fMRI studies in the early 2000s, they discovered that social rejection activates overlapping neural pathways with physical pain, though the experiences aren't identical. The intensity is neurologically distinct. The speed is instantaneous. There's no gradual buildup of hurt feelings over time. And most importantly, it's triggered by perception, not reality. An unanswered email, a slightly different tone of voice, a meeting request with no context, these ambiguous social cues get interpreted as definitive rejection before conscious evaluation can occur. Dr. William Dodson, who brought clinical attention to this pattern in ADHD practice, describes it as a tidal wave of emotion that arrives without warning. Adults in his clinical practice report emotional responses that seem disproportionate to outside observers but feel completely justified in the moment. This isn't dramatic exaggeration, it's what happens when the brain's threat detection system operates with different calibration settings. What makes the "just be less sensitive" explanation appealing is that it puts you in control. If this is a character flaw, you can fix it with willpower and better thinking. If it's just anxiety, you can use standard anxiety management techniques. But rejection-sensitive dysphoria resists these approaches because it's not primarily a thinking problem or even an anxiety problem. It's a neurological difference in how certain brains process and regulate social pain. To understand how rejection-sensitive dysphoria works, imagine your brain's threat detection system as a smoke detector. In most people, this detector distinguishes between actual smoke and burnt toast. It activates when there's real social danger, but stays quiet for minor social ambiguities. In brains with RSD, the detector operates at maximum sensitivity. The slightest hint of social smoke triggers a full-scale fire alarm. The established neuroscience shows that social rejection activates the anterior cingulate cortex and the right ventrolateral prefrontal cortex, brain regions that process social pain. Eisenberger's research demonstrated that these same areas light up during physical pain, though the experiences remain distinct. Your brain processes both types of pain through overlapping neural networks. In ADHD brains, there's an additional factor. The prefrontal cortex, the brain's executive control center, shows altered dopamine signaling patterns. This affects the neural circuits responsible for emotional regulation, impulse control, and contextual evaluation. When the smoke detector activates, there's reduced capacity to evaluate whether the threat is real. Here's the sequence that clinical observations suggest. An ambiguous social cue arrives. Your friend takes 6 hours to respond to your text instead of their usual 2 hours. In a typical brain, the anterior cingulate cortex registers this as a mild social irregularity. The prefrontal cortex quickly evaluates context. They might be busy, their phone might have died. This doesn't necessarily indicate relationship problems. The emotional response stays proportionate and brief. In an RSD brain, that same 6-hour delay gets flagged as potential rejection, but the prefrontal cortex's regulatory signals appear weaker due to dopamine differences. Instead of contextual evaluation, you get what Dodson calls emotional flooding, intense shame, anger, or despair that feels completely justified in the moment. The emotional intensity can persist for hours or days, long after rational analysis would suggest the trigger was meaningless. A 2019 study by Kuj and colleagues found that adults with ADHD showed greater activation in emotion processing regions when viewing rejection-themed images compared to controls. Their brains were essentially treating neutral or mildly negative social cues as emergencies requiring immediate emotional response. The neurotransmitter picture involves both dopamine and norepinephrine differences, yet systems that ADHD medications target. This may explain why stimulants and certain other medications can reduce RSD symptoms in some people, not by changing personality or building resilience, but by affecting neurochemical signaling in emotion regulation circuits. Think of it like trying to have a reasonable conversation. While someone plays music at maximum volume in the next room, you can still hear words, but the emotional static is so loud that precise social information gets drowned out. RSD occurs when your brain's emotional volume control is stuck on high, making it nearly impossible to distinguish between minor social friction and genuine rejection. The research picture becomes more complex when you examine the details. Rejection-sensitive dysphoria isn't in the DSM-5, and for good reason, while we lack standardized diagnostic criteria and large-scale epidemiological studies. Dodson's clinical observations suggest that the vast majority of people with ADHD experience some degree of RSD, though controlled research studies show more varied prevalence rates. The replication picture is mixed. While Eisenberger's social pain research has been replicated multiple times across different labs, the specific connection between ADHD and heightened rejection sensitivity rests on smaller studies with varied methodologies. A 2021 meta-analysis by Michelle Mowry found that rejection sensitivity is indeed elevated in ADHD populations, but the effect sizes vary considerably across studies, and many studies have small sample sizes or lack adequate control groups. There's also the question of causality. Does ADHD brain structure directly cause rejection-sensitive dysphoria, or does RSD result from years of experiencing more actual rejection? People with ADHD often do face more criticism and social difficulty throughout childhood and adolescence. Impulsivity, attention problems, and emotional dysregulation can strain relationships and academic performance. RSD might develop as a learned response to genuinely higher rates of negative social feedback. Michelle Mowry's longitudinal research suggests both factors contribute. Children with ADHD show elevated rejection sensitivity even before they've accumulated extensive negative social experiences, suggesting some neurological predisposition, but the intensity of RSD symptoms correlates with the number of actual rejection experiences over time, suggesting that environmental factors amplify the underlying neurological vulnerability. The autism connection adds further complexity. Many adults discover they have both ADHD and autism, and rejection sensitivity appears in both populations. But the mechanisms might differ. Autistic individuals might experience RSD due to difficulties reading social cues accurately, leading to genuine confusion about social situations, while ADHD-related RSD might involve accurate social perception, but dysregulated emotional response. Clinical populations reveal additional layers. People with borderline personality disorder also show intense rejection sensitivity, but the emotional patterns differ. BPD-related rejection sensitivity often involves fear of abandonment and interpersonal chaos, while ADHD-related RSD focuses more on perceived failure or criticism. Trauma survivors can develop rejection sensitivity that resembles RSD, but responds differently to treatment. The medication response adds another puzzle piece. Stimulants help many people with RSD, but not everyone. Alpha-2 agonists like guanfacine, which affect norepinephrine rather than dopamine, help others. Some people respond to MAOIs, a class of antidepressants that affect multiple neurotransmitter systems. This suggests that RSD might actually represent several different neurological patterns that produce similar symptoms. We genuinely don't know whether rejection-sensitive dysphoria is one condition or several. We don't know why some people with ADHD develop severe RSD while others don't. And we don't know whether the apparent increase in RSD diagnoses reflects better recognition of an existing condition or changes in social environment that make rejection sensitivity more problematic. If you recognize yourself in this description, the first thing to understand is that your emotional responses aren't a character flaw or a failure of willpower. When someone with RSD feels devastated by a colleague's neutral feedback or panicked by a friend's delayed response, their nervous system is responding to what it genuinely perceives as a threat. The pain is real even when the rejection isn't. This reframe matters because it changes your relationship with the experience. Instead of, I'm being ridiculous and need to stop overreacting, the internal narrative becomes, my threat detection system is giving me information that may not be accurate, and I can learn to work with this rather than against it. Practically, this means developing what clinicians call emotional surfing. the ability to experience intense emotions without immediately acting on them or assuming they reflect reality. When you feel that familiar crash of shame or panic, the goal isn't to make it stop immediately, but to create space between the feeling and your response to it. The medication conversation is worth having with a healthcare provider, especially if RSD significantly impacts your work or relationships. Many people report that ADHD medications don't just help with attention and focus. They turn down the volume on rejection sensitivity enough that social interactions become manageable again. This isn't emotional numbing, it's more like getting glasses for social perception. But medication isn't the only tool. Cognitive behavioral therapy techniques can help you develop more accurate ways of interpreting ambiguous social cues. When your brain screams, "they hate me," because someone didn't laugh at your joke, you can learn to ask, "what are three other explanations for this response?" Dialectical behavior therapy offers specific skills for managing emotional intensity when it does arise. The social environment piece matters too. If you have RSD, certain contexts will be more triggering than others. Highly critical workplaces, relationships with poor communication patterns, or social groups that rely heavily on subtle cues and unspoken rules will be more challenging. This doesn't mean avoiding all potentially difficult situations, but it does mean being strategic about where you invest your emotional energy. Understanding RSD can also change how you interpret your own behavioral patterns. That tendency toward perfectionism or people-pleasing isn't necessarily low self-esteem. It might be your brain's attempt to minimize rejection risk. The chronic exhaustion after social interactions isn't introversion, it might be the cognitive load of constantly monitoring for signs of disapproval. Recognizing these patterns as neurological responses rather than personality defects opens up different approaches to managing them. Rejection-sensitive dysphoria reveals something profound about the relationship between brain structure and social experience. For decades, we've treated intense rejection sensitivity as a psychological problem requiring psychological solutions: better self-esteem, more rational thinking, thicker skin. But RSD appears to be primarily a neurological difference in how certain brains process social threat, which means it requires neurological solutions alongside psychological ones. Your emotional responses to perceived rejection aren't a measure of your maturity or resilience. They're information about how your particular nervous system is wired, and once you understand the wiring, you can learn to work with it rather than against it. The goal isn't to stop feeling social pain, but to develop a more accurate and manageable relationship with the pain you do feel.